And finally, we'll go over some case discussion just to bring the concept of life to life. Finally, we will talk about career paths for you all if you're interested in joining transplant nephrology. And hopefully by doing this, I can inspire you as you explore your healthcare careers. So first, I will start sharing my own path. So my background might be a little bit different from you. I'm an international medical graduate. I'm originally from Syria, which is a small country in the Middle East, which is known for its history and good food. I graduated from high school. I was among top 1% high school graduates in my country. Then I moved to United Arab Emirates, where I joined Dubai Medical College between years 2005 and 2011. After medical school, I joined internal medicine residency in United Arab Emirates between 2011 and 2015. After that, I worked for 2 years in the same hospital as hospitalist. During those 2 years, I gained experience and I found my interest in nephrology. So I decided to pursue my career in nephrology. So I moved to the United States, where I joined nephrology fellowship in UIC between 2017 and 2019. After that, I got further training in transplant nephrology between 2019 and 2021. And since 2021, I've been working as a transplant nephrologist at the University of Illinois in Chicago. So the decision to join medical school started with my interest in science and biology and my willingness to help other people and some of family influence. All of this led to my decision to join medical school. Medical school for me was 6 years at Dubai Medical College, and the structure was 5 years of core training, followed by additional year of internship training, which is hands-on experience, where I built my foundation of knowledge. And at that time, actually, I didn't have no idea that I would be joining transplant nephrology for my career. For residency training, I joined internal medicine residency, where I learned to manage a wide variety of sick patients. So I became comfortable taking care of very sick patients in the hospital. I rotated into different specialties of medicine, including pulmonology, cardiology, nephrology, GI, neurology, hematology, infectious disease, and rheumatology. And here I was exposed to nephrology in a serious way, especially caring for patients with kidney failure in the hospital. After the residency training, I worked as a hospitalist for 2 years. And this role gave me a valuable experience in being the primary physician managing patients admitted in the hospital. And during those 2 years, I learned to take responsibility and to become more independent and how to coordinate care with different specialties. For nephrology fellowship training, it's 2 years of training. And nephrology focuses on kidney disease, hypertension, electrolyte disturbances, dialysis, and kidney transplant. And here was my first experience with kidney transplant. And during the 2 years, I learned a lot about kidney disease. And also I saw how dialysis can both save lives and also create new challenges. In 2019, I began my transplant nephrology fellowship training, which is a subspecialty that focuses on patients before kidney transplant and after kidney transplantation. And during this training, I had experience to deal with kidney transplant patients in outpatient setting, in the inpatient settings. Also, I learned about transplant infectious disease. I learned about transplant hepatology. and also in-depth training about immunology and immunosuppressive medications, and also medical research. Now, let's shift gears a little bit and talk about the organ I deal with, which is the kidney. So the kidney is a bean-shaped organ that's located in the back. Humans have two kidneys, and they are bean-shaped organs, and they are very smart organs. Every kidney contains millions of filtering units called nephron, and the nephron consists of glomerulus and tubules. The function of the glomerulus is to clean the blood, to filter waste products, and the waste product will be collected in the tubules all the way down to the collecting ducts and eventually out of the body. So kidney has three main functions, mainly excretory function. So kidney excrete waste product, excess water and electrolytes, and also eliminate drugs and toxins. Hello? The second function of the kidney is the regulatory function. So as I told you, kidney is very smart. The kidney can regulate blood pressure, acid-base balance, and osmotic regulation. And kidney has endocrine and metabolic function. So kidney keeps the balance of calcium, phosphorus. It also activates vitamin D and also produces a hormone called erythropoietin that stimulates bone marrow to make more red blood cells. So what's the how to measure the kidney function in the clinic? So we check serum creatinine, which is a serum marker for kidney function. So creatinine is a waste product, and the kidney excretes creatinine in the urine. So in cases of kidney failure or kidney damage, serum creatinine will increase. From serum creatinine, we measure or estimate glomerular filtration rate, GFR. And the kidney function is assessed using a creatinine, and out of creatinine, we estimate GFR. So what's the normal kidney function? Normal kidney function is when GFR is more than 90 ml per minute. When GFR less than 90 ml per minute, we start thinking about kidney disease. And when GFR is less than 60 ml per minute for 3 months at least, this is when we diagnose chronic kidney disease. And when kidney loses its function completely, when GFR is really low, this is the stage of kidney failure, or what we call it end-stage kidney disease, or end-stage renal disease. So here I have a question for you. What do you think the most common cause of end-stage renal disease in the United States? Is it hypertension, kidney stones, infections, or diabetes? You can type in the answer in the chat box. So I see diabetes. Any other text? Hypertension. Okay. So actually the most common cause of end-stage renal disease in the United States is diabetes. So here it comes a question, a very important question. What are the risk factors of kidney disease? Who would develop kidney disease or chronic kidney disease? So risk factors include diabetes, hypertension. Yes, hypertension is one of the risk factors of kidney disease, but it's not the most common. Then we have obesity, we have genetics, we have chronic infections such as HIV and hepatitis C infection, and we have chronic use of nephrotoxic medications. So what is the disease burden? Is it common to have chronic kidney disease worldwide or in the United States? So actually 14% of US adults are estimated to have chronic kidney disease, which is about 35.5 million people. Unfortunately, kidney disease is asymptomatic until advanced, really advanced. So 9 out of 10 adults with chronic kidney disease, they don't know they have it. And about 1 in 3 adults they have with severe kidney disease, they don't know they have kidney disease. So how do we stage kidney disease? We stage chronic kidney disease based on the GFR. So normal GFR is 90 or more. And as GFR drops, patient progresses through the stages of kidney disease. And the final stage of chronic kidney disease is called end-stage kidney or renal failure or kidney disease. This is when the kidney loses permanently nearly all functions. So what happened after reaching end-stage renal disease? What's the survival? So the median survival without any treatment is typically days to weeks because toxins, excess water, and excess electrolyte will accumulate in the body and will lead to fatal consequences. So patient can live days or weeks without any treatment after reaching end-stage renal disease. So what's the incidence of end-stage renal disease in the United States? So if you look here at the incidence of end-stage renal disease between 2002 and 2022, you can notice that incidence has been increasing over time. It has increased between 99,000 up to 131,000, which is a significant rise, and this reflects an increase of 31.3%. So my next question to you, do you think there is a cure for kidney disease? Is there a cure for end-stage kidney disease? Yes or no? You can type the answer in the chat box. True, false, false. Okay. Good. So the majority are saying false. Very good. So I agree with you. No cure for end-stage kidney disease. So what do we do with those patients? What can we offer? So we offer something called renal replacement therapies. Those are ways to replace or partially replace the kidney function. So we have hemodialysis, we have peritoneal dialysis, and the third method is kidney transplantation. Now let's talk a little bit about dialysis. So dialysis is a medical treatment that does the job of the kidney using a machine. And dialysis uses the concept of diffusion. So in the dialysis filter, we have a semi-permeable membrane, and then small molecules will pass across the membrane from the high concentration to the low concentration compartment. And by doing this, the machine will clean the blood. So we have the first form of dialysis or first modality of dialysis. It's called hemodialysis. For hemodialysis, we need an axis, a vascular axis. So the vascular axis is either a fistula, arteriovenous fistula created by the surgeon, or a hemodialysis catheter inserted into the patient chest. So the blood will flow from one end of the port, will go through the machine, and inside the machine, inside the filter, the diffusion will happen, and then clean blood will go back to the patient's circulation. For hemodialysis, patient will need to do 3 to 4 hours of hemodialysis 3 times a week. This can be done either in center hemodialysis or at home. The other form of dialysis, we have something called peritoneal dialysis. And for peritoneal dialysis, we use the membrane lining the abdomen called peritoneal membrane as the semi-permeable membrane. To perform peritoneal dialysis, we need a peritoneal dialysis catheter inserted also by the surgeon into the patient abdomen. And through the catheter, we infuse the dialysate fluid inside the patient abdomen. and then we leave it for a certain amount of time, and then the diffusion will happen, and then we drain the waste fluid out. And this procedure will be repeated overnight, and on average, patient will do 8 to 12 hours of peritoneal dialysis. And usually this procedure is done overnight while patient is sleeping. And patient can use a machine to help with peritoneal dialysis called a cycler. So this is dialysis. Then the other way of renal replacement therapy, we have kidney transplantation. And for kidney transplant, a kidney from a donor will be transplanted into the recipient. Then the transplant kidney will be connected to the bladder. And to have the kidney transplant functioning for a long time and to prevent rejection of a kidney transplant, the recipient should take immunosuppressive medication for the rest of their life. So who can get a kidney transplant? Any patient with end-stage kidney disease who is interested in transplantation? Anyone without any contraindication to transplant? Referral, we prefer referral to be done early when GFR is less than 30 ml per minute, because the transplant process is time consuming. So early referral is ideal. And ideally, the transplant should take place before patient requires dialysis. What are the pros and cons of the different forms of renal replacement therapy? First, I will start with dialysis. So although dialysis can keep patient alive, right, through filtering or cleaning the blood, but it has lower quality of life. The patient should spend long time doing dialysis. Patient should follow strict diet. And in order to perform the dialysis, we need an access, especially hemodialysis, we need a vascular access. And for peritoneal dialysis, we need a peritoneal dialysis catheter inserted. And dialysis has a higher mortality rate compared to transplant. Now, what are the pros and cons of kidney transplantation? First, it's better quality of life. Patient will have more time to do his daily activities. Patient can work, they can go to school, they have like nearly normal life. There are fewer dietary restrictions with kidney transplantation and better survival compared to the dialysis. What are the cons? So sometimes it's hard to find a living donor. It's a surgery. And also patients should take medications for the rest of their life, every day. Waiting time can be long, especially if waiting for a deceased donor transplant. A patient will need lifelong medical follow-up and lab studies. So what is the status now? What are we doing for our end-stage kidney disease patient in the United States? As you see from this graph, the majority of patients are receiving in-center hemodialysis, as you see this blue line. And only few number of patients are receiving a preemptive kidney transplant. And what we mean by preemptive kidney transplant is transplantation before initiation of dialysis. So why kidney transplant? Because although dialysis can keep patient alive, but it limits quality of life. And also kidney transplant improve quality of life and reduce mortality risk compared to dialysis. So always is remember that kidney transplantation is the treatment of choice for end-stage renal disease if they have no contraindications and they are eligible for transplant. And remember also, it's not cure. End-stage kidney disease is not, there are no cures for end-stage kidney disease. So where do we get the transplant kidney from? So it can come from a living donor or a deceased donor. So living donor, they give better outcomes, but it's a big a bigger personal sacrifice. And for deceased donor transplant, it depends on the allocation system, and also it has longer waiting time. So what are the pros and cons of living kidney donation or living donor kidney transplant? So living donor kidney transplant lasts longer because usually the donor is very healthy. There shorter waiting time. You don't have to, the patient should not wait for very long time in order to get the kidney. And planning is easier because surgery is elective surgery. What are the cons? Sometimes it's hard to find a donor, and it's hard to ask people to become a kidney donor. Now, for deceased donor kidney transplant, what are the pros and cons? So you no need to ask for a donor, but it has longer wait time. It lasts shorter, and it has higher risk of dying while waiting for the kidney on the wait list. So to summarize this part, living donor kidney lasts between 15 to 20 years on average. Some of them last longer than this time. And deceased donor kidney transplant lasts between 10 to 15 years on average. So what's the current picture nowadays? So here in this graph, you can see the national kidney wait list addition per year. So every year we have around 34 up to 37 for this year so far, 37,000 addition to the kidney transplant wait list. So many patients are added yearly to the kidney transplant wait list. What are the numbers in terms of actual transplantation? So the number of kidney transplants are less. Around 19,000 only are receiving kidney transplant per year. This highlights a bigger problem, which is organ shortage. And with time, the kidney transplant wait list will expand over time. And wait time is a bigger problem here. So at any given time, we have nearly 90,000 people in the United States are waiting for kidney transplant. And 11 people die every day while waiting for a kidney transplant. So what are the steps of the process? So it starts with evaluation, and then the surgery, then recovery period in the hospital, followed by lifelong monitoring and lifelong medications. So for evaluation, patient will come to the clinic where they will meet the transplant nephrologist, they will meet a dietitian, will meet a PharmD, pharmacist, and they will meet with a social worker, cardiologist, nurse coordinator, and a surgeon, transplant surgeon. We all work as a team to evaluate the eligibility and to ensure there are no contraindications to kidney transplants. So what's the role of the transplant nephrologist during the evaluation? They assess the overall health of the patient. They assess different organs like heart, lung, liver, to make sure there are no contraindication to the surgery. Then also to assess blood and tissue matching. So we do multiple blood tests to assess if the donor kidney is compatible with the recipient to ensure successful transplant and to reduce risk of rejection. And also we assess for infection and vaccination, so to ensure no active infections and vaccinations are up to date. Also review of medical history and medication, including cancer screening in order to plan for the surgery and recovery period. And lifestyle and support evaluation to ensure that patient has the enough support at home and they can follow the instructions and they can follow the medication after transplant. Now, let's talk a little bit about history before moving forward to the future. So the first kidney transplant, cadaveric kidney transplant, was done in 1933 in Russia by Dr. Voronoy. while the first cadaveric human kidney transplant in United States was done in Chicago by a urologist called Dr. Rickard in 1950. And the first successful human living donor kidney transplant was done on December 23rd, 1954 at Harvard Medical School by Dr. Joseph Murray. And as you see here, this is a very famous photograph published in the New York Times after the first successful kidney transplant. Now, what are the rates of rejection after kidney transplant? So this graph will show you the trends of acute rejection after kidney transplantation. In 1965, 1 year rejection rate was more than 80%. At that time, we didn't know a lot about immunosuppressive medications. But over time, we started discovering or developing different medications that suppress the immune system, called immunosuppressive medications. And with use of different immunosuppressive medications, we noticed that the 1 year acute rejection rate has significantly dropped in the year 2020. So it's very important to remember that after transplantation, patients should be on lifelong immunosuppressive medications, and they need lifelong follow-up. Why this is important? Here comes the role of transplant nephrologist. So the transplant nephrologist will find the right balance between medication side effects, infection, malignancy, toxicity, and kidney rejection. So we try to stand here in between the middle. We don't want to see kidney rejections. We don't want to see side effect or infection or malignancy in our patient population. That's why monitoring and laboratory studies are very, very important to titrate medications. So what's the role of transplant nephrologist? First, we start before the transplant. We start by evaluating the recipient. So we see the patients with end-stage kidney disease. We evaluate them in the clinic. We evaluate any living kidney donor. We also prepare patients before the transplant surgery. For example, optimizing medical status, prescribing immunosuppressive medications. After surgery, we adjust immunosuppressive medications, and we monitor patients for any rejection or any complication after surgery. And also, we treat any complications after transplant, such as kidney rejection or infection. It's team approach, so no transplant happens without a team. So we work closely with transplant surgeon, nurse coordinator, nurses, pharmacists, dietitian, social worker. We all share responsibility. It's teamwork. What do you think about our day? Do you think it's very hard, very hectic? No, actually, in fact, it's very interesting. It's very fun. So what you need to survive in transplant nephrology, you need good communication skills. You need to communicate with empathy. You need to pay attention to the details. You need to have critical thinking. And transplant nephrology provides the perfect mix between inpatient and outpatient services. So in the inpatient services, we round in the ICU, and we round in medical floors. We have multidisciplinary rounds. We round with a large team of transplant surgeon, dietitian, pharmacist, social worker, nurse, fellows, resident, medical students on the team. You can be on call for cases of emergency like rejection and infection. And also we prescribe dialysis sometimes for patients with acute kidney failure or for patients with failing kidney transplant or cases of acute rejection. For outpatient clinic duties, we evaluate patients, both recipients and donors. We follow the recipient in the post-transplant clinic, and also we follow the kidney donors in the post-donation clinic. In some programs, transplant nephrologists also perform transplant kidney biopsy and transplant kidney ultrasound. So we need those skills as well. For administrative duties, transplant nephrologists attend several meetings, attend transplant recipient eligibility meeting. During this meeting, we review the workup of end-stage kidney disease patient to evaluate if the recipient is eligible to be on the wait list for kidney transplant. We attend a living donor workup meeting to review the workup of living kidney donors and to assess, to ensure safety of kidney donation. And we attend adverse event meeting where we review any adverse event or patient death and put measures to prevent any adverse event in the future. And also we attend a quality improvement meeting and we implement projects focusing on improving quality. For research experience, it's mainly focused on improving outcomes of kidney transplant recipients and prevention of complications such as infection and rejection. Also, there are ongoing research trying to minimize or eliminate the use of immunosuppressive medications after transplantation and exploring alternative therapies, including xenotransplantation. Now we'll go over some cases. I'll ask you a few questions also. You can type the answer in the chat box. Okay. So first case is a 55-year-old female patient who received a living donor kidney transplant around 1 year ago. And after transplant, her kidney function was stable, was normal. And her prescribed immunosuppressive medications are listed here. There are 2 medications, tacrolimus and mycophenolate. She came to the emergency room with a complaint of vomiting. And she said she was not taking her medication. She had no fever, no diarrhea, no shortness of breath, no changes in urine output. And her examination was normal. And here the table is showing the lab studies. So serum creatinine is 6.5. The normal is between 0.5 to 1. BUN is another test that we use to evaluate kidney function, and it's also high at 55 milligram per deciliter. Electrolytes, sodium, potassium, and glucose are all normal. And additional labs were done to look for infection, and all were negative. So this is a patient with acute kidney injury. Creatinine worsened over a short period of time. Her creatinine was 0.9 2 months ago, and she's coming now with a creatinine of 6.5. And this, in this case, we can say patient with acute kidney injury. So what do you think? What do you think could be the cause of the kidney injury? So we think about 3 different lines. First, it can be from any condition that leads to decreased blood flow to the kidney, like hypotension or dehydration or volume depletion. Or it could be due to intrinsic kidney injury, like infection or rejection or any other kidney disease, or obstruction if the urine is not flowing as it should. So kidney ultrasound was normal and blood pressure was within normal, and we started the patient on IV fluids. So the next step, we got a kidney biopsy. So the patient was not taking her medications. and she has acute kidney injury. So what do we expect to see in the biopsy? You can type in the chat box if you want. Okay, very good. So could be immune system attacking kidney due to not taking medication. Very good. So in medical terms, we call this rejection, right? So here we got the biopsy of in our patient. For your reference, I put the normal tissue on the top of the slide. So as we see, those are tubules. Those circular structures are tubules. They have one layer of cells. They are nice back to back. There are no much space in between the tubules. This is normal tissue. Now, what happened with our patient? So we have this is one tubule, this is another tubule, and this is the third one. They are separated by inflammatory cells. So immune cells are attacking the kidney, separating the tubules. And also, instead of one lining layer of cells, we see multiple layers. And some of those cells are immune cells attacking the tubules of the kidney. This is called tubulitis. And those those findings can be seen in acute kidney rejection. Here is another section. So this is a normal arteriole in the kidney. And in our patient, we see also immune cells attacking the arteriole. And this is also a feature of acute rejection. So what happened after in this patient? So this patient received treatment for rejection, and usually treatment of rejection is immunosuppressive medication, to give additional immunosuppressive medication. And her creatinine improved down to 1.5 milligram per deciliter. So I'll go over another case, but before going to the next case, do you have any question about case one? No? Okay. So for case two, here is another patient who is a 51-year-old patient who received deceased donor kidney transplant 9 months ago. And this patient is coming to the clinic for follow-up, routine follow-up. And his or her prescribed immunosuppressive medications are tacrolimus and mycophenolate. And this patient was taking medications regularly, on regular basis. So examination was normal. Blood pressure, heart rate, oxygen saturation, and examination was normal. But what you notice in the clinic, you notice that serum creatinine is 2. And BUN was slightly high at 30 milligram per deciliter. You looked back at the chart and you noticed that serum creatinine was 1.2 3 weeks ago, and now it's 2. Urine analysis was negative. You ordered an ultrasound of the kidney transplant and it was normal. So what do you think? What's going on? Any thoughts? Okay, so we check a test called the BK virus, serum BK virus, and came back very high. So what's going on in this patient is that she's having an infection called BK virus. So we get a biopsy in this patient, and as you see in this slide, the tubule has very large nucleus due to presence of viral inclusion bodies and also immune cells around the tubules. So the BK virus has infected the kidney. And we have a special stain called SB40 and it's positive in cases of BK nephropathy. So the BK virus infects kidney, and over time, the normal tissue of the kidney will be replaced by scar tissue. And over time, patient can lose their kidney transplant because of BK nephropathy. So what is BK? BK is an infection. It's very common in general population. It infects around 80 to more than 90% of population. And primarily infection can happen during early childhood, and it results in persistent infection of urinary tract, and it's asymptomatic. It won't cause any symptom in healthy population. However, the immune system cannot eliminate the virus completely. It stays in the urinary tract as inactive. And what happens when immune system is weak? So what happens after kidney transplant when we give immunosuppressive medication? Those medications can lead to uncontrolled viral replication, and the virus can affect or infect the kidney. And this can lead to a condition called BK virus nephropathy, which is a leading cause of kidney transplant failure after rejection. So what do we do for, what did we do for our patient? So unfortunately, we don't have a effective therapy for BK virus, but the first line treatment is to lower or to reduce immunosuppressive medication. So to give a chance to the immune system to fight the virus and clear the virus. While doing this, we monitor for any signs of kidney rejection. So again, we should find the right balance between rejection and infection. So we lower the immunosuppressive medication to the level where patient can control or immune system can attack the BK virus, but we monitor for any signs of rejection while reducing immunosuppressive medications. So what is the path to the field? So it starts with undergrad, and then you have to join medical school. And after medical school, internal medicine residency, which is 3 years of training. After that, 2 years of nephrology training, where you learn about kidney disease. And additional 1 year of transplant nephrology fellowship. Only 1 year of training after nephrology. And then you learn about transplant nephrology, immunosuppressive medication, and how to manage different complications after transplant. It's a long road, I agree with you, but worth it if you love the field. So what makes transplant nephrology fascinating? First, you see immediate life-changing impact on patients. So you see patients are off dialysis and they are getting their life back. Only few specialties in medicine offer such dramatic and visible improvement in quality of life. It's a balancing act of immunology. So managing the immunosuppression is like fine-tuning a delicate scale. So if you give too much immunosuppressive medication, you end up with infections and cancer. And if you give too little immunosuppressive medication, you end up with kidney rejection. So it's always interesting. It's highly complex, so never routine. Patients are medically complex. Usually patients will have multi-organ issues, infection, rejection, drug toxicity. So every day feels different, and problem solving is central to this job. Teamwork at its best. So in transplant nephrology, you don't work in isolation. You work with huge team of surgeon, coordinator, pharmacist, social worker, dietitian, nurses. Few fields demonstrate multidisciplinary care as clearly as transplantation. Also, allocation decision forces you to confront fairness, justice, and cultural issue. You witness also the generosity of living donors and legacy of deceased donor. It's very exciting for me in transplant nephrology that I got to practice science along with ethics and humanity all at once. And cutting edge medicine, so exposure to research and innovation, trying to develop novel immunosuppression biomarkers of rejection and xenotransplantation. Also, you build long-term relationship, unlike surgical fields. You follow patient for a very long time. You follow patient for years. And you build a deep connection with patients. You see them growing. You see them returning back to work. You see them having families. It's longitudinal care at its best. Also, it has global relevance. So kidney transplantation is needed everywhere. Lessons you learn in this particular region is applicable across different health systems. And you'll have opportunities for international collaboration and humanitarian impact. Where do transplant nephrology work? So you can work in hospital and academic centers, usually large medical centers with kidney transplant programs. They can work in private practices. So nephrology group can collaborate with a transplant center, and you can see a kidney transplant patient within the private practice group. You can work in a university or medical school. You can focus on research and teaching. You can educate medical students, resident fellows, and participate in clinical research. Also, you can, as a transplant nephrologist, you can practice general nephrology. You can do dialysis, you can see general nephrology, and also at the same time, you can practice transplant nephrology. So what's the take-home message from today's presentation? Kidney transplant is the best treatment for end-stage renal disease. Transplant nephrologists balance complex medicine, teamwork, and ethics. And the field offers immediate impact on patient life and long-term relationship. It's intellectually stimulating and deeply rewarding. It's very, very challenging. And my advice to you is to stay curious and to keep asking questions whenever you can, and to build strong foundations in internal medicine, to seek mentorship and shadow experience early on, and to be open to fields you may not have considered before. Thank you for your attention, and thanks again for inviting me to give this talk. And if you have any questions, please let me know.
Hello, everyone. So this is Walaa from Pre-Health Shadowing. I am a lead volunteer liaison, and right now I'm just gonna voice out your questions. So if you have any question for Dr. Dabbas, I will just be the voice to your question. You can put it in the chat. Oh, okay. So I think there was like a previous question in the chat. I'm not exactly sure what the question says, could immune system attacking kidney due to not taking medicine injures kidney? I'm not sure exactly the question says. So if you could please type it out again. We have one question which says, what is your favorite thing about being in your profession, Dr. Lam?
Okay, so my favorite thing about being in this profession, so I like taking care of patients, and I like to see I'm making changes in the patient's life. And what I like about transplant nephrology, that you build like long-term relationship with the patient. You have this strong connection with the patient. So you see them growing, you see them graduate. I have patients who went to school, nursing school, they graduated from school, they started their job. I have other patients where I was following when they were on dialysis, and then they got transplant, and I saw them like having family, getting pregnant, having kids. So this is very, very rewarding. And also, as I mentioned in the talk, like in transplant nephrology, you see an immediate change in patient life. Like they get off dialysis, they are free of dialysis. They can do, they have freedom to do more things in life. They can work, they can live like near normal life, like off dialysis.
We have a couple more questions.
Yes.
The second one says, is the kidney donor waiting list determined by first come, first serve, or the degree of the patient's kidney failure?
So, in order to be on the wait list, patients should meet like criteria, eligibility criteria, which is creatinine less than GFR less than 20 ml per minute. And we have a system where the patient will get points on the wait list. For example, patient get points for dialysis time. They get points if they were a previous donor, like if a previous donor and in 10 years, this donor developed kidney failure. So they get additional points for if they were living donor in the past. They get additional points if they are close to the donor hospital. And they get additional points if they are completely matched with this donor. So it's a complex program, and then we use the software to allocate like which kidney goes to which recipient.
I think that was a wonderful answer. Um, Someone asked, can we shadow a transplant nephrologist? I think the person is asking like in person if there are like opportunities to shadow in person.
Yes, yes. We have sometimes like students are joining our team to shadow either with a transplant nephrologist or a surgeon, or because we work as a one team, so we have like a lot of interaction with the students. Yes, we have a shadowing opportunity in transplant nephrology.
Yeah. And then we have one question. Is there anything you wish you would have known before becoming a doctor?
Okay, that's a good question. So I was the first doctor in my family. I would say I went into medicine like without blindly. I would say I had many pharmacists, but I didn't have any doctors in the uh, family. So I was exploring my healthcare career, I would say, with the help of mentors. But yeah, I think I would have known. Like I would say to have an advice to find a mentor early on during your job, like to find a mentor to put you on the right way to help you like explore like what you want out of the medical career. Yes.
Think that's a wonderful response. As someone who comes from a family of accountants and being the only one pursuing a career in healthcare, I think I'm currently like looking for someone who is I guess who has already kind of built a career in the field I would like to go into. I think that is an amazing. Someone asked, okay, well, well, how do we actually find the right mentor? I think this is a great question.
Okay, so I know you are just starting your medical or healthcare career. You might not have very clear goals, but try to have like maybe one big goal that you want to achieve, and then try to find mentor. Actually, more than one, right? Try to define your goals first. They should not be very very clear, but at least you should define your goal, and you search for the mentor from your network, maybe someone from your medical school, or even if you can have mentor like nowadays we have like online, you can meet with your mentor online like on Zoom or virtually. And you can have more than one mentor, because like one mentor will be you may choose a mentor who's like very advanced in research, and another mentor who's like more into clinical. So try to find more than one mentor, and uh, try to achieve and try to classify your big goal into small goals, so you can like you can achieve the goal easier.
That's a good response. I have a question from Sarah. She says, in the pictures, it shows a transplanted kidney and the original diseased kidneys in the same person. When you transplant kidneys, do you not take out the diseased kidneys?
Okay, that's the picture. You should transplant it. Yes, that's a good point, Sarah. Yes, so when the surgeon transplants the kidney, they don't remove the original kidney. The original kidney will stay where they are. Because with kidney failure, the original kidney will become small, they shrink in size, they are like fibrous tissue. Unless we have a problem with the native kidneys, like if we have very big cysts or we are suspecting cancer in the native kidney, we remove the kidney. Otherwise, they stay where they are, and the transplant kidney will be transplanted in the lower part of the abdomen.
I think that was a quick question because I didn't know that. I always just assumed they took out the diseased kidney. But that's a great response, and that
So
makes
that's
so
what I
much
know.
sense now.
That's very
So we
common.
have another question which says, what do you like about your job?
I like teaching the fellows and the students.
Mhm.
I really like helping others and providing like education and sharing my experience.
Mm. So this question will kind of take you back to memory lane. Do you have a favorite memory from medical school or from residence?
I remember one patient that I saw during my residency, and so I did my residency in the United Arab Emirates, and at that time they didn't have a transplant program.
Mm.
Patients used to travel to different countries to get their kidney transplants. So I had this patient who was like who did his kidney transplant at another country, and he just came back. And he used to wake up like midnight, like 2 or 3 a.m. to take medication based on the time of the other country. And I was
Oh.
surprised. Like I asked him, why is that? And here I realized how important this kidney transplant for those patients. He said they cannot take any chance to have this kidney fail, even if I wake up like 2 a.m. to take my medication.
Mhm.
So that story touched me and made me think like how important is the kidneys are. Like we don't realize how important they are. We have like normal kidneys. Like if you have two normal kidneys, it's like really a blessing.
Mm. This next question, I think you've kind of answered like part of this next question. It says, how did you know you wanted to become a doctor and what specifically drew you to nephrology? I think you've kind of answered that part of it in the first one.
So for becoming a doctor, I had interest in biology to start with in high school. And
Mm.
then I had like my personality and my character. I like to help people and to give to community. Plus, some direction from my family influenced my decision. So that's why I joined medical school. And then for nephrology, during the residency, when I was training, so nephrology is very interesting because it's close to medicine. It's you see many cases, like a lot of cases, diverse cases, and then um, you deal with electrolytes. It's a lot of calculation, a lot of thinking. It's like puzzle. It's like a very interesting field. So that drew me to the nephrologist.
Okay, so we have one question from Vincent. It says, what factors do you look for before letting someone shadow you? Do you have any advice for finding doctors to shadow? I think these are both great questions.
Yeah, my advice, as I said, just be courageous, ask questions, and consider any medical field. Don't say I want to do, let's say, dermatology, or I want to do pediatrics only. Stay open,
Mhm.
open-minded to other specialties. You never know. You may try something and you may like it.
Mm. Do you have any advice for finding doctors to shadow?
There are many doctors around, who are willing, and they really like to help students. Um, and same as mentor, try to find multiple doctors to shadow, to learn from. And even within transplant nephrology, even if you shadow with a transplant nephrologist, multiple transplant nephrologists, your experience will be different with each one of them. It won't be the same.
Yeah. So we have another question from Bui. It's a she or they say, what was the most challenging and rewarding case?
So we see a lot of challenging cases every day. It's not like one case that I remember on top of my head, but we see a lot of challenging cases every day. Situations where we need to, like a patient with a new diagnosis of cancer, and now they have perfect kidney function. The kidney function is perfect. They're doing great, but unfortunately they have cancer. So we have to lower the medication, and then the anxiety that comes to the patient with that adjustment. So it's very, very challenging. I would say a lot of cases are challenging in transplant nephrology. Like we have patients with cancer, we have patients with serious infection, brain infections, like serious infection, like brain infections, and they have kidney transplant, and they're doing great in terms of kidney transplant. And here in this situation, we have to lower the immunosuppressive medication. So a lot of challenging cases we face every day. And the rewarding cases are actually the ones we see after transplant. So the moment they wake up after the anesthesia and after extubation from transplant surgery, they are very happy. So patients are really happy to make urine, because with end-stage kidney disease, end-stage kidney failure, those patients will stop making urine. So when I see them after transplant, they start making urine again, and they are so happy with that. So even simple making urine makes them really, really happy.
That's a great answer. Another question says, what would be some ways to avoid burnout as a physician? And do you do anything in particular to ensure you have a healthy work-life balance?
Okay, so burnout, physicians in general are at risk of burnout with whatever specialty you choose. I spoke with my friends in psychiatry, in pediatrics, in different fields, and all they're at risk of burnout. That's the reality. But what we do, we have to separate. Like you have to draw a line between the life and work, right? You should find time for yourself. You have to find time to read, to go outside, to meet with friends, to have time for you, for the family, to feel feel refreshed and go back to work and to give other people. Without this, you can't survive in medicine.
That's definitely a good answer. Now, for your specialty, how much of your time do you spend with patients versus doing administrative work or like paperwork? How much time? What's the ratio like?
So for me, majority of my time is spent with patients. I don't have a lot of administrative roles. Maybe I would say 10% is admin role, and the rest I spend with patients. But as a transplant nephrologist in general, you can take more administrative role, and the person can change based on what you want to do. Like if you want to become like a program director, or if you want to become the director of the transplant center, you can take on like more administrative duty.
Okay. I think that's a great ratio. Let me ask one question. If you weren't if you weren't in this specialty, what specialty would you have chosen?
So before joining medical school, I really wanted to become a pharmacist. And actually, I'm very happy that I joined transplant nephrology, because it's a lot of medication and it's a lot of pharmacology in transplant nephrology. So yeah, I wanted to become a pharmacist.
Mm. It's really interesting. And mm, well, what would you say is your least favorite part of the job?
Okay, so I know it can be challenging sometimes,
Mm.
uh, or it can be very busy, but also those can make it also very interesting at the same time. My least favorite part is when I see patients like losing their kidneys
Mm.
and very upset about it. They're crying, and at some point you cannot do much to help in those situations, like patient with failed kidney transplant, uh, or patient who are like mainly it's failed kidney transplant, where patients are really um, upset about the fact they're losing the kidney. So there's a lot of emotion. But again, like even failing kidney transplant is not the end. The patient can go back to dialysis and they can get evaluated for another kidney transplant.
Mhm. Another question says, now I know you see a lot of unhealthy kidneys, but what are the tips or advice would you, or what tips or advice would you give us to better care of our kidneys?
So in general, healthy lifestyle, right? Kidneys are very sensitive organs, and I would say follow healthy lifestyle, like eating healthy, avoid smoking, avoid obesity. Annual checkup are very important, because as we learned from presentation, kidney disease is silent, can present without any symptoms. So until very advanced, kidney disease will not have any symptom. So the only way to diagnose or to detect early is to check the blood test, to check the serum creatinine. So like adults should go to the annual checkup yearly to check kidney function and to check risk factors of kidney disease, like things that can lead to kidney disease, like diabetes and high blood pressure, and also um, smoking or any condition that can lead to chronic kidney disease.
Okay, so we have a question from Ashwa, and it says, what specific tests are ordered for diabetic patients to make sure their kidneys are healthy? I like this question because it's very specific.
So, what test we should order to check the health of the kidney?
Yes, of a diabetic patient.
Oh, okay. So, very good question. So, one is
Mhm.
serum creatinine that evaluate the filtering function of the kidney. And the other test that we should do in all diabetic patients is a urine test to check for protein in the urine, particularly one type of protein called albumin, because this is one of the earliest sign of kidney damage in the diabetic population.
Okay. So we have another question that says, how harmful are energy drinks to kidneys, and what about having cortisol levels or having high cortisol levels? I'm sorry, can you hear me? Hello?
Yes, so in general, I would say ultra processed food are harmful for the kidney. Like
Okay.
additives, artificial sweeteners are unhealthy and they can affect or increase the risk of kidney disease.
Okay. Um, we have a question from Sarah, and it says, "What doctor do you go for to check for kidney disease?" Now, I know you deal with when kind of more progressed stages, but if I were, for example, I wanted to go check my kidneys out, even though I don't necessarily see um the most obvious symptoms, where would I go?
You can start with a primary care doctor, like internal
Okay.
medicine, family medicine doctor. They can start the screening with a blood test and urine test. And if they have any problem, or they can refer the patient to the nephrologist.
We have another question from Boy, and it says, how does nephrology differ from other internal medicine subspecialties?"
So, um, internal medicine is a
Mm-hmm.
specialty where you learn about all internal, like medical subspecialties. You learn about all of them. But in nephrology, you specialize in the kidney disease. So different specialties, they have different. For example, some specialties, you do more procedure. For example, in nephrology, we don't do a lot of procedure, right? While if you choose to do cardiology, you can do cardiac angiogram, or pacemaker placement. Other specialties like GI, also it's a lot of hand-on, like you do the endoscopy, upper and lower endoscopy, and ERCP, so multiple procedure. Some ID is similar to the nephrology because ID or infectious disease is like affect multiple organs. Like it's complex and also it can affect multiple organs.
Mm-hmm.
So
So I'm gonna say, oh, I'm sorry.
I wanted to say, just when you join medical school, you can learn a little bit about all those subspecialty and you realize the difference and you can find your interest.
Oh. So I'm gonna take the last two questions before we run off. Um, how often should I go to the nephrologist to get checkups?
So Um, for the checkup, I advise patient to go to the primary care doctor. Like we start with a primary care physician, or
Mhm.
like family medicine, internal medicine. They start the screening with chronic with a blood test and urine test.
Mhm.
And if the screening test showing any issue, kidney issues, they get referral or like referral to see the nephrologist. And depending on the degree of kidney disease and the type of kidney disease, the nephrologist will decide the frequency or of the checkups.
Okay. And the last questions says, what was the other part of the medical journey and how did you deal with it?
Okay, so I think I answered a similar question before
Mhm.
about
Oh,
the hard
yeah, you did.
part of medical school is when I see patients like going through a hardship or like losing their kidney transplant.
Mhm. Yes. If there are no more questions, I'm gonna go ahead and round off with 1 second, everyone. I want to share my screen if that's okay with you, Dr. Dabbas.
Okay. Oh yeah,
Yeah.
you stop sharing.
Okay, so can everyone see my screen? Thumbs up, thumbs up, if you can see my screen. Can you see my screen? Thumbs up.
Oh,
Okay, great. So let's reflect on what I was going to say. We've gained so much information from Dr. Dabbas, and I just want to say thank you before I even thank you so much for taking the time out to speak to us. We really appreciate it. We are shadowing appreciates it. The students of the meeting appreciate it. And just to reflect, the first question, what brought you to the session today? What brought you to the session today? Were you curious about nephrology? Are you trying to explore um different um specialties? Is this your first time shadowing with your shadowing? What brought you to this session today? You can just type it in the chat and just, wait on that for a couple of seconds. Kidneys are amazing organs. I agree. And I think I've learned so much about kidneys just by this. And I think the one thing that I really like, I'm like, oh, like diseased kidneys aren't actually taken out of the that was definitely. Wanted to know more about shadowing. Yes, this is a great place. Peer shadowing is a great place to start with just virtual shadowing to kind of get a feel for shadowing doctors and other healthcare career leaders. Curiosity about what nephrology is saying. I came here to have a better understanding about Dr. Dabbas' specialty in nephrology and shadowing itself. That is great. So now, what are three major takeaways you got from the presentation? I have already said mine. Let me see what's been said. Okay, someone said this was my first time doing any shadowing, and I've always heard about kidney failure in my community. That's what I wanted to learn about. Amazing. So let's talk about our takeaways. What were your most interesting parts of the presentation? What were you like, wow, like I never knew this, or like what made you, what's under your light bulbs? I would say what created a spark? What was the interesting thing about today for you? Just gonna wait on that for a couple of seconds. Hmm. But it is important to take care of your kidneys, but if you don't, we hopefully can get help with wonderful physicians such as the back. Okay, no wait on that. Any other person? What was your major takeaway? It doesn't have to be three. You can tell me one major thing you learned or that you didn't know before. It could be about residency. It could be about the specialty itself, healthcare. Yes. Just wait for 10 more seconds to see if. Okay. Wait 1 second. That nephrology is a rewarding specialty to go into. It's saying without kidneys, we wouldn't survive for more than a week. That's definitely interesting. That's definitely interesting. Gotta take better care of my kidneys. Um, okay. And that's all. So we have um multiple shadowing sessions a month, and we would like to know what you would like to learn about. What do you want to see more in our shadowing sessions, I guess. Um, Someone said P is a blessing. Yes, it is. You know that now. Another one says seek a mentor based on your goal, explore various medicine majors, and recognize the importance of our kidneys to our quality of life. That's great. Do you offer in-person shadowing opportunities? Currently, we do not. Kind of our niche is more virtual shadowing opportunities for students. So we are more, that's kind of our niche. Our niche is kind of virtual. We do everything virtual, like shadowing, but we do not offer in-person opportunities. right now. Hopefully we do in the future, but right now we do not. Um, our goal is to make it more make shadowing opportunities more accessible to people. Um, but we always have like sessions like this. Any other suggestions? I'm just gonna wait for like 10 seconds and then we
I would like to thank you once again for inviting me to give this talk.
oh,
It's
thank
really
you.
nice meeting you all, and I hope you all the best, and hopefully you will be a great doctors in the future, all of you.
Thank you so much. Thank you so much. So to share your insights on today's session on prayer shadowing at all, you can share a post, share your certificate of participation, and just tag us on there so we can, give you a little words of encouragement by tagging us at prayer shadowing. And if you're interested in being a part of
I'm so sorry. I don't know where our host went, but I'm Abraham. I'm the department head of student success here at Real Shadowing. I think we can wrap up, you guys. Thank you so much for your time today. Dr. Dabbas, again, you have such a wonderful presentation today. It's our honor and our privilege that you came here today. But thank you all for being here today. We are about to upload the quiz very soon. But again, thank you very much, all of you guys, for our time today. And have a wonderful rest of your day. Bye, guys. Take care.